Hey, DNA. Kate Wilson, your one woman wolf pack, is here with another episode of All Access DNA. In today's episode, we are talking to Samantha Stover, she, her, about prenatal diagnostic testing. Sam is a reproductive genetic counselor in the Division of Maternal Fetal Medicine and assistant in obstetrics and gynecology at Vanderbilt University Medical Center. We cover chorionic villus sampling, or CVS, and amniocentesis, as well as why someone may choose or not choose to undergo genetic testing. We also talk about patient autonomy, informed consent, and variability in insurance coverage. Let's get started. So, Sam, we're excited to have you today.
Thanks for having me.
So, I think first off, why don't you tell us a little bit about how you got into prenatal genetic counseling?
Yeah, I originally thought I wanted to be a zoo vet and then went to NC State and I realized I loved a lot about the zoology field and I thought I wanted to do herpetology and eventually just realized that wasn't for me long term. And there was a period of time where a close family member of mine was advanced maternal age and looking to expand their family and went through quite a bit of just not great circumstances for both prenatal and fertility workup. So then it had more of a personal effect, I guess. And then I remember taking Dr. McKenzie's class at NC State
Mm-hmm.
and love him. And then he had brought in a genetic counselor to come talk to the class. And I thought, well, I'll go shadow one, see how I feel. Uh, and it ended up being truly the thing that put me on the trajectory to be a genetic counselor. I always felt this affinity to prenatal, and so as my first shadowing opportunity, and that's specifically what I went and did at the UNC prenatal clinic. And then from there, it felt like the perfect fit. I felt inspired by it, I felt excited. And so from there, I just did whatever I could to do the slog of getting into grad school.
Mm-hmm. I would say, and similarly, so for those that don't know, Sam and I went to the same undergrad university. Both had Dr. McKenzie, who introduced us to the world of genetic counseling. You go to graduate school, you learn about genetic counseling. Was there something in particular that drew you to the prenatal setting as opposed to some of the other specialties?
I think it just felt more personal in that I really, even at the time it was all happening, I was late high school, but and then into college, I just did not like the way my close family member was kind of treated by a lot of providers, or at least the effect that it had on them. And it just felt like it wasn't as compassionate. I don't know. And so I kind of had that drive. I wanted to make this field better, or at least help patients. I always loved doing work where I could help others and feel like I had an impact. And I loved genetics and science, so it felt like that perfect fit. Of course, I love animals, so I thought to myself, I'll just volunteer in other things to still fill that cup. Um, I will say, when I got into grad school, there were actually some specialties that I didn't realize were out there, just didn't know as much about, that I did really like. Others where I knew it would be tough just because of family history, like cancer. I knew from the jump I would never be a cancer genetic counselor. My father had cancer, and so it was just too close to home in a different type of way. Um, but over the years, I just especially continued to love like embryology and the, just learning about how do fetal anomalies happen. I felt like I could give a lot to that area and help these patients more than necessarily other clinics.
Mm-hmm. And you mentioned the phrase advanced maternal age. So I know that is one that is can be touchy phrase. I think I've heard some patients who've come in and say, "I've been told I'm an old mom or
Yeah.
I'm geriatric mom." So I wondered if you,
Elderly multigravida.
yes, so I
That's
wonder
the diagnosis code.
if you can kind of explain what that term refers to, and is it still something that people are being seen for or having genetic counseling for these days?
Right. So, what I tell my patients is that back in the day, so decades ago, and I believe it was Dr. Joey Biggio at UAB, where I went to grad school, that told us this. It's pretty much just a bunch of doctors in Europe who set this standard of 35. It's because at the time they were looking at if you were to have an amniocentesis, which is an invasive test we can do during pregnancy where we take a sample of the amniotic fluid and there's a small risk for miscarriage. So they're looking at what's that risk for the procedure, and then when is it the same as someone's just what we call age related risk to have a pregnancy with Down syndrome. And basically, when that risk for Down syndrome went above the risk of the procedure, that's where they drew the line of advanced maternal age, which at the time was 35. So I tell my patients there's nothing magical that happens at 35. There's nothing insane that happens. Just as we age, our eggs age with us. And over the
Mm-hmm.
time, the process of just passing on chromosomes doesn't work as well as we'd like. You're just more likely to pass on more than expected. Now, of course, once you get above certain ages, certainly the risk can feel much higher for many people. Um, but at 35, it's not like there's this massive jump. And I also tell them, that kind of the context of how that risk came to be or that cutoff. And it's funny because nowadays, if you were to use those same parameters, it would be like in your 20s that you're considered quote unquote advanced maternal age.
Hmm.
Um, because of how much the risk for amniocentesis has dropped, at least procedure related
Mm-hmm.
miscarriage risk. And ultimately, I think the field has been shifting away from singling out the counseling for pregnant patients who fall into that category, or at least making it so specific, like we're referring for genetic counseling. At least that's been my experience in the last few centers I've worked. We also really tried to empower the providers on why we don't necessarily need to see those patients, why that counseling can be done in their office, so that we could have more spots available for patients who, say, had a high risk screening result or a family history or something on ultrasound, basically getting more towards kind of higher risk cases across the board instead of someone coming in, they're 35, 36, 37, us telling them, yes, you fall into this category, but we're still going to offer you all the same screening diagnostic testing. I think where some patients still get referred, it's if it's kind of, I don't want to say higher age or older age, because it's not like I think my patients are old by any
Right.
means. It's just feel like there is more pressure to send someone when they're, say, over 40
Hmm.
versus right at 35. Um, and I will say there are just some effects that aging can have on our body when it comes to pregnancy. So it is still relevant to talk to OBs or midwives or nurse practitioners or maternal fetal medicine specialists about the risks that can come along during a pregnancy when you are just aging. But that's not necessarily all genetics. There are things as well, like just pregnancy related complications or risks that they like to talk to patients about that are still important to keep in mind. And I think since I've now compared to when I started, there's definitely not as much weight, I think, put on that hard cutoff of 35. Um, I see way less patients nowadays for that indication than I did when I first started.
Mm-hmm. And that was my hunch as well. I mean, it's been a while since I've done prenatal on the clinic side, but that was not as large a volume, I would say, of patients being seen. So you mentioned that patients, now sometimes are having some screening done with their OB first, and then potentially coming in for a further evaluation, maybe with a genetic counselor or an MFM, maternal fetal medicine specialist. One of the things is we talked to another genetic counselor about prenatal screening, so some of these screening tests that are
Mm-hmm.
available. With our conversation, I wanted to focus a little bit more on what we call diagnostic testing. So maybe you can give us an overview of what the difference is between the prenatal screening piece and then the prenatal diagnostic testing, because they're sort of two different categories.
Yeah. And so for prenatal screening, we're not getting a direct fetal sample. A lot of the screening nowadays, at least, is done by reading through these little fragments of DNA that are really coming from the placenta. And ideally, the placenta and the fetal DNA or chromosome makeup should be the same, but there can be some things that happen just randomly in the placenta or started off that way at conception, and certain cells kind of change over time. And so you can have these differences between the placenta and the fetal DNA. With screening or with diagnostic testing, we're trying to get that yes or no answer. So with screening, we can never say yes or no purely based on those DNA fragments. There are certainly tests where you can have more confidence that it's accurate versus possibly a false positive or even a false negative, meaning it wasn't correct.
Mm-hmm.
With diagnostic testing, there's a few different ways to go about it. There's two in particular we talk about more frequently, which is chorionic villus sampling and then amniocentesis. Chorionic villus sampling, or CVS, I do feel like it has a bad reputation because it does have a higher risk of pregnancy loss associated with the procedure. But what we're doing is taking a part of the placenta. We usually aim for, at our center, we try to get patients between 12 weeks and the end of the 13th week. You can sometimes do it a little earlier. Really just depends on the placenta. If the maternal fetal medicine specialist feels like they can get a good sample. Sometimes we'll do them later than that too, than the end of the 13th week. With CVS, there is that big caveat of we're still testing the placenta. So there are some things to consider, like is it actually representative for what is going on in the fetus? With my patients, I always tell them CVS can still be a great tool, even if we don't see anything on ultrasound. If someone wants more information, there's about a 1 to 2% chance where we find something that we do need to clarify with later testing, which is the amniocentesis, and I'll get more on that next. But CVS, most centers will say 1 in 500 risk for miscarriage. It's kind of the best general risk we have based on a lot of data, just nationally. Some centers will even say 1 in 1,000, especially if they do them all the time.
Mm-hmm. So
So it is lower.
it
Yeah.
can vary depending. So if you're going in to a
Yes.
center, ask them what they typically say the
Yes,
risk is.
absolutely.
Okay.
Yeah. And the reason why I say that and why I say it has a bad reputation is because online, a lot of numbers I've seen listed on websites are outdated. We used to say 1 in 100, 1 in 200, 1 in 300. It kind of depended on the center. But 1 in 500 is based more on big meta-analysis or review of a lot of literature.
Mm-hmm.
And truly, I know providers who will tell you, I say less than 1 in 1,000. And like Dr. Robert J. Carpenter in Houston or Dr. Mark Evans in New York City, I know for a fact they'll say much lower. They do them all the time. Other providers I've worked with, same thing. They have their own kind of personal risk number that they'll provide. And CVS, especially if you see something on ultrasound, it can be very valuable, unlikely to be different from the fetal DNA. The other thing I always like to tell patients about is traditionally CVS was done when we saw something on ultrasound. So if you're earlier in pregnancy and there is an ultrasound anomaly, we know a lot of those can be due to chromosome conditions that just have a higher rate of miscarriage or just a fetal anomaly in general. Earlier on in pregnancy, we know you can have a higher rate of loss. So there is a question of, for some patients, was it the procedure versus was it something that may have just happened
Mm-hmm.
in general
Or
based
the
on the underlying
underlying
cause?
condition or what was going
Right,
on.
right,
Got it.
right.
And you mentioned the other test that can be done besides a CVS is an amniocentesis. So what's different about the amniocentesis?
Yes. So that is a little bit later in pregnancy than CVS. Most places will say 16 weeks and after. Really, there are these membranes that need to fuse together. It usually happens around that time. And what we're doing is taking a few tablespoons worth of fluid from the amniotic sac. I tell my patients it's very similar to when you're sitting in a bath, your skin cells come off in the water. Same with baby, but also they're constantly drinking and peeing out that fluid all over again. So it's full of cells from their skin, from the inside of the body. And so it is a much more direct sample of we're truly getting fetal DNA. And we also have ways to confirm for sure that it's fetal DNA and not maternal, because you do have to go, through the body to get to that amniotic fluid. And with amnio, really, once you're past that point of the membranes fusing, you can do it at any point. I've had patients who had it at 37 weeks before delivery. Why it happens that late versus earlier just really depends on the scenario, the patient. But for amnio, we say the risk of a miscarriage or procedure-related loss is about 1 in 1,000. Once you get to around 24 weeks, it's not really a risk for miscarriage, because that's, for many centers, what we call the point of viability, meaning when can a baby survive outside the womb. So for those patients, it's more risk for preterm labor or sending them into labor. But there was a recent study from an international cohort that looked at, is the rate different for patients after 24 weeks versus before, as far as having a major complication, and we found it's really not. So it is a safe procedure throughout pregnancy, as long as there's nothing else going on. Like if someone has way too much fluid, or they have contractions, or definitely things that can affect that. But the amniotic fluid is nice in that it is one of the most representative samples.
Mm-hmm. And the difference then you had mentioned earlier between screening is telling us this is a possibility, this may be going on, but the purpose of doing a CVS or an amnio is to try to get as close as we can to a definite, yes, this is happening, or no, this isn't happening.
Yes,
Okay.
for
How
sure.
how
We're trying to
accurate?
get 100%.
Okay. Well, I was going to say, so how accurate is CVS or amnio? Is it 100% or not quite? Because I know you mentioned CVS, we're kind of getting some cells from the placenta, not maybe directly from the baby itself.
Right. CVS, I always say, comes with a caveat, a disclaimer of about, just in general, 1 to 2% of samples we find mosaicism, meaning some cells have a certain chromosome makeup, others have a different one. I explain to my patients, if they've ever seen a mosaic tile piece of art or other things, it's really similar, just made up of different parts. So if you don't see anything on ultrasound, even if you do see certain things, the question is, okay, what's the percentage of that different makeup in the fetus? Or did those abnormal cells or cells with a chromosome difference or genetic change, did they make it to the fetus at all? There are absolutely things that just happen in those cells in the placenta where it's kind of like a little pocket. It could be the reason you're having a high risk result. We could have just randomly found it on CVS, but it's not actually affecting the pregnancy, or at least fetus.
Mm-hmm.
If you see things on ultrasound, and to give very clear cut answer or example, say someone has a high risk screening result for trisomy 21 or Down syndrome. They come in, we see extra fluid on the back of the neck. Maybe the nasal bone isn't as big, it's kind of what we call hypoplastic, it's smaller than expected. Those are things that we can see with Down syndrome earlier in pregnancy. So if a CVS came back saying trisomy 21, Down syndrome, at that point, yes, we didn't test the actual fetal DNA, but for all intents and purposes, we consider that diagnostic,
Mm-hmm.
because it is matching up. And there's many other examples we could go through. Now, if you didn't see anything on ultrasound, there is always that question of, could it not be the same in the amniotic fluid? depends on the condition as to whether that is still likely to match up versus
Hmm.
truly only being the placenta.
Yep. And I think we talked about this in a few of the other episodes where it isn't necessarily a straight, clear cut, you do this test and it tells you all the things. Like it's just part of the puzzle that you're putting together. So it helps whether the results are positive or negative, they can be informative, but it's really how it's taken into context of all the other things, like you said,
Right,
ultrasound findings, other things that are happening.
right. And there are definitely some tests that we can do where even without ultrasound, it is clear cut and that we know there's going to be certain features or, if we find certain conditions. Others, there's a lot more gray where we can't necessarily predict every impact that we can see from that condition. CVS, though, is a little trickier in that the mosaicism can really affect what we say, what we think is going on. Amniocentesis, you can sometimes still not have 100% clarity on something, especially with certain conditions that we just know have that mosaicism, but it is far more likely to be okay, yes, this is truly fetal versus, we're not testing the placenta, we're
Hmm.
testing the amniotic fluid. So it can kind of take out a lot of those worries.
So it could be probably a little less uncertainty, I guess, with an amnio because you don't have that 1 to 2% risk for, like you said, that mosaic option or possibility.
Right. And you can still find mosaicism randomly, like in the fetal cells, but that's at least a different conversation that we know it's coming from the fetus versus, oh, the placenta, which could be totally different, right? And we don't have truly fetal cells that we're looking at.
Yeah, and it's less uncommon to see that on an
Yeah.
amniocentesis. Yeah. So you mentioned like trisomy 21 or Down syndrome, and that some conditions may be, I guess, easier to find on a CVS or amnio, but some may be more difficult. What are some of the more not necessarily common, but I guess why are some of the reasons that people are having the prenatal diagnostic testing? What conditions are they looking for?
So I it's definitely going to vary based on where you are in the country as far as think how likely someone is to get diagnostic testing just because. Me being in the South, I definitely do still patients who come in or have patients who come in and say, I just want more than what you can get from the screening, which really for CVS, for amniocentesis, usually where we're starting are the chromosomes or those packages of our genetic information. We at our center will often look at not just how many of those packages are there, but also could there be any missing or extra pieces of information. And I tell my patients it's like we're looking at a map and we're trying to see, imagine, look at all the states. How many states are there? Did half of Florida go missing? Did a new state pop up between Tennessee and North Carolina? And then the other test is very similar to zooming in on Google Maps and trying to see how many towns and cities are there. Did a suburb go missing from Nashville, or did a new town pop up between here and Birmingham? It can also tell us is there a big chunk of the desert that went missing and we don't think anything's in there. There are definitely parts of our genetics, just like parts of the landscape where it wouldn't necessarily be as big of an impact on person, whereas others where there's much more impact. So it very much depends on what is missing, what is extra.
So there's sort of like two different layers or maybe filters where you have one where you're looking at kind of big areas, like you said, states, and from sort of a more high level view, and then others where you said like you zoom in and it's a town or a city or a neighborhood even, and you're getting even more, I guess, smaller areas of information.
Right. And then whether it's CVS or amniotic fluid, even cord blood from a fetus, there's other deeper testing we can do where it's much more similar to driving down a street and looking at all the houses on a street. Are all the colors of the houses what we expect? Did a house go missing? Did a new house come in? Did addresses get flipped? And usually when we're going to that level, it's because something is going on. Either we see something on an ultrasound, or there's a family history of a condition, or just other kind of factors for someone's history. There are some centers that are offering that in depth of testing, even when we don't see anything on ultrasound. That gets a little trickier because you might find something different with a really small amount of genetic information where you can't totally say, oh, this is going to cause a condition, right?
Mm.
Similar if you're driving down a street and you think a house used to be gray, but now it's white. You're like, I don't know if that's really an issue. Versus if a house totally went missing and it was an essential house on the street, it's a little more cut and dry.
So it sounds like then there are a lot of different conditions that you can find on prenatal diagnostic testing, but depending on whether you have the test that looks at like the big packages of chromosomes versus the ones that look at the much more detailed information may depend on one, what center you're being seen at as to like what they're offering.
Yes.
And then two, it may depend too on just what's going on with the pregnancy. So, are there ultrasound findings? Is there a family history? So, when there's other risk factors or things that make the provider concerned, they may say we need to do a more detailed test.
Right.
Mm-hmm.
Yeah.
Well, I was going to say, and I know this was one of the popular questions I got with patients when I was in clinic was, is there a test that tests for everything?
So there is technically, or at least there is a test that looks at a lot of information. Some people may have heard about it in the news or read about it, called whole genome sequencing. We can do that prenatally. It is just, it can be much harder to know, for one, what to report, because, like I said, there are changes where it's not like you have the person in front of you, right? To know their full life story, or do they have any physical differences that might point towards certain conditions or not. We're very much limited to what do we see on ultrasound, or if you have a like, fetal MRI or fetal,
So you could
echocardiogram.
it's like you could find something and you could be like, this is something that is totally normal and this person's
Right.
going to develop, this kiddo is going to develop fine. We don't need to worry about it, but we just don't know enough about the genetics right now. So we could find something and we could say, we just don't know enough. It could be fine or it could be an issue, but we just don't know.
Right. Or if it's a change no one has seen before, and these genetic changes, a lot of people over time have said mutations, we kind of say variants now. Um, for those variants, it might just be unique to that family, or it's not actually changing how the body understands that instruction. And if you've never seen it before, it's not like you have the luxury of saying, oh, well, look at this other variant where we've seen it 100 times and we know for sure it makes the body not understand that instruction. So sometimes, even if you're suspicious, you just don't have the luxury of saying, oh, 100% we know this is the cause. Um, Other times it's more complicated that maybe it has been seen before, but it can still show up differently in different people. And the other thing I think a lot of patients don't realize is that we don't even know what all the genes in the body do, as far as if you do have some type of variant that causes it not to work or not to work as expected, what condition does that actually lead to? So
Mm-hmm.
there are definitely patients where we get results where we don't have a name for a condition. We think the change is very suspicious, but we may not have answers for years, if ever. Or maybe it's been seen 50 times in the world, but no one has ever reported how it presents in a pregnancy. So we're still really limited by that.
Mm-hmm.
And we can get a lot of information, but we are very much still limited as far as what we can tell patients.
Well, and so that might be a reason why somebody says, yeah, we'll look at the chromosomes or the big packages because we know about those. We've been
Right.
testing those for a while. And then that way we can give you some more concrete info. But if we look further or more in depth, we could get more information that's useful, but we could also get more information that we just don't know what to do with.
Right. And I do still tell my patients, even with kind of the tried and true chromosomal testing. I think anybody having CVS, amnio, they really should have informed consent and detailed what we call pretest counseling, because you still can get some pretty uncertain
Mm,
results on those tests. Even one of the really classic ones where we're looking at how many packages of those chromosomes are there, you could still find something where they have seemingly an extra copy of a chromosome, but it's not as straightforward, like where it came from. It's just not as what we call high resolution, like you can't see as many details. So even for those classic tests, that should always be, I think, part of any prenatal, really any genetic testing that's done in the pretest counseling. Also for the screens, which might have come up in your other podcast.
yeah, and I think that that's an important call out is whether it's a screening or a diagnostic test, that informed consent is a huge piece of it, because you want people to know here's what it can tell us, here's what it can't tell us, here are like the risks, right, associated with
Right.
something like this. So is prenatal diagnostic testing, so a CVS or amnio, is it something that a physician will tell a patient, no, you absolutely have to have it, or is it up to the patient if they're going to have this diagnostic testing?
It's always up to the patient. Um, we absolutely have situations where not just myself, but other team members are explaining to patients this would be so beneficial to have, to help for better planning, to help understanding like what this baby might need at birth. Or if I have patients who are strongly considering ending a pregnancy and they want yes or no answers on what could be going on, I tell them, then get it, because
Mm-hmm.
I can't tell you 100% until we take that next step. Um, I do feel strongly, though, that even if a patient is feeling like they're being told, oh, you have to have this, really, you don't have to have it. I'd say it's always their choice. The
Yeah.
big kind of exception to that is if someone is a candidate for what we call fetal surgery or fetal intervention. There's just many examples of what we can do to try to intervene in a pregnancy. Then it can be required.
Hoping to do a full episode on fetal intervention
Yeah.
and surgery, because I feel like that's a whole other
Oh, it's a
thing.
whole hour of conversation.
Yes, but I
Yeah.
think that that's good for folks to know that, I mean, typically it's going to be their choice if they want to go ahead with this testing, but I think like you said, that's part of the informed consent, is that the
Hmm.
provider, the genetic counselor is going to say, look, if we do it, here's what we could potentially learn. Here's
Right.
how that information might change what we would do in the pregnancy or what we might offer to you during the pregnancy. But again, it's still your choice, but here's kind of
Right.
the things that we could gain from it.
Right. And I think if I wanted listeners of this episode to really take away from this, you would think that I would be mainly pointing out, oh, you should know about all the things we can find from this testing. If anything, what I want people to remember, though, is that it is impossible to say, oh, yes, your fetus, your pregnancy is 100% healthy with a normal result. And to really keep in mind the limitations of each test, because I see that a lot where someone may have had diagnostic testing because we see something on ultrasound, then they come to our center for more counseling, and it only went to a certain level, and they were under the impression, oh, we're good, like we completely ruled out every genetic possibility. So it doesn't feel awesome to have to come in and
Mm-hmm.
say, well, actually, that's not the case, even if they've had the most in-depth testing. And it, while I would love to be able to say, oh, yes, like we found everything or we looked at everything, I just can't. So even with the most advanced testing, it's just not possible.
Yeah, and I think that's, again, that's part of giving that information is
Hmm.
being forthright with what we can and can't do, because we just have or don't have the knowledge for some of these things. Still, we're still learning about a lot of the genes, like you said, and figuring out what some of them do. And I think that's what's interesting about genetic counseling, is that you're going through all this technical information, like you were talking to us about the options with the testing, the ins and
Right?
outs, but you're also helping these patients navigate the emotional side
Mm-hmm.
of, do I do a test that puts my pregnancy at risk? And that's, can be very challenging. How do you help patients kind of weigh those more complex decisions or those emotional decisions rather than just focusing on the information?
Right. Something I often say to my patients is they have to think what keeps them up at night. So for some patients, it's going to be, what if I'm that one in a thousand? For other, or at least for pregnancy loss. For others, it's the thought of what could be causing this, and they're just kind of racking their brain and really want more information. Even if it's not a high chance we'll find something, for some patients, having that negative result might be what they need. For others, they don't want that information before delivery or even before a termination. Um, and they'd rather, have testing done later, if at all. For some patients, I do think it gets to test fatigue, especially for some of our patients who have already been through a lot of testing, a lot of ultrasounds, a lot of screening. I have for sure had patients where they said, yes, I want this information, but I am so burnt out on what we might find, right? And they just need a break. And my goal is to get to the bottom of that for each patient on like how they feel about uncertainty, how they feel about having a diagnosis of ahead of time or even ruling out. It's very different between each patient. Sometimes it comes down to practical things of they would want more testing, but we know insurance wouldn't cover it. Or we can't test because there's not any fluid and they might be going into preterm labor, right? There's different reasons. I think what's most important though is making sure they're comfortable in their decision. Because if they do, whether they decide to have it or not, at the end of the day, I don't want them to feel coerced. And I also want them to be able to live with their decision, whatever it may be.
And helping them get to that point where they're not constantly second guessing themselves, like you get
Right,
them to a point where they feel comfortable in the decision that they've made.
right.
Mm-hmm. So you mentioned a good piece, which I was going to get to, is insurance, because I think that's always a concern when we're talking about like the genetic testing side of the space, and it's one of the ones we've asked some of our other guests to in certain areas. Tell us about what you've seen just in terms of, does insurance cover this type of testing? What is the cost for something like a CVS and amniocentesis? How does that look like for a patient?
The cost, big disclaimer, it really depends on where you're at. And is it through a hospital? Is it like, does the hospital do the billing versus do you go straight to the lab? Typically, just when you're looking at like the list prices for some of the more standard tests, it, like for example, a big picture of all the chromosomes, also called karyotype or chromosome analysis, I think on average it's probably around $1,000, give or take. Some labs are cheaper, some are going to be more. Same for the one that's zooming in, we call it a chromosome microarray, looking at any missing or extra pieces of information. And on average, you see that between like 1,500, maybe a little more, a little less. Um, when you're talking about really in-depth testing, looking at those single, pieces of our genes, it can vary wildly. On the prenatal side, there are some labs that will do, um, for example, whole genome sequencing for maybe like around $2,000 to $3,000. Others that charge 5,000 for self-pay pricing. It can vary wildly between labs. And also those prices include, there's another version of the test called whole exome sequencing or prenatal exome sequencing. It's a little, it's not as in depth as genome. It is more widely available. There's more labs that do it. Still only a handful, but more than genome. Um, Insurance, we have guidelines saying every pregnant patient should be offered diagnostic testing to include chromosome analysis and the chromosome microarray if they get a CVS, if they get an amniocentesis. That's been out for a few years now from American College of Obstetrics and Gynecologists, and I think it was a joint guideline between them and Society for Maternal Fetal Medicine. Ever since that came out, which I believe was around like 2017-ish, give or take, maybe 2016, it's gotten so much better for insurance coverage for those. I hardly ever have patients come to me saying they got a denial for those tests now. Even if we don't see anything on ultrasound, they just wanted it for their own information. For the other more in-depth testing, it really depends on the insurance company. There has been, I feel like, a little more success over the last few years for getting exome sequencing covered. We've been ordering that on the prenatal side for, I know for myself personally, 10 years now, so others a little bit longer. So it has been around to where some insurance companies, I think, are open to it depending on the circumstances. But there are also many who consider it experimental or it's not medically necessary. I will say, for any people listening who might have to go through that testing, oftentimes those denials, and this is kind of across the board for insurance, it is usually not even someone in that field as far as who's saying, oh, you're denied. But when you appeal it, it's supposed to go to someone in your realm. So for the ones I've appealed, I've had more success in getting it covered because it went to like a maternal fetal medicine specialist or an OB/GYN or a geneticist, and they have more understanding of like the nuances and why we would do it. The really frustrating thing is that even if you try to get approval ahead of time, vast majority of the time, if it is quote unquote approved, like for a pre-authorization, there's a disclaimer saying, but when you actually run this test, we can just decide what we want to do at that point. So you can jump through all these hoops and still can't guarantee that it's actually going to be covered. Mm-hmm. And that unfortunately is part of the counseling for a lot of my patients of kind of have to take that leap of we may get a denial, we can try to fight for it, but I can never say 100% is going to be covered. There are some patients where we just check and we know upfront it doesn't matter if you get a pre-auth, flat out they're never covering it, and so they might go the self-pay route. One thing I do worry about just for our field is equity, because it's not a cheap test, especially for those more in-depth ones, and I've absolutely had patients who they just couldn't afford it, even though it would have been so valuable to have before baby delivered or say they terminated. There's just a big question of access across the board, I think, for prenatal genetics in general, especially for diagnostic testing.
Yeah, it's a challenge too, because like you said, in the United States, because we have listeners, some not in the U.S. So in the U.S., since it is big with private health insurance, it can be tricky to know what's my out-of-pocket cost, what is this going to cost me, and like you said, there are still some times where a test may be ordered, the sample is sent, and we still don't necessarily know for sure
Right.
all the ins and outs. So I think it sounds like, I guess the best piece of advice would be to tell patients to work with their provider. They may be able to get like codes for the test being run and talk to their insurance company. So there's some stuff you can find out, but sometimes it still may be hard to know 100%.
Yeah. And I will say for the appeals process, I have had some where it just, they kept the denial. I've had others though that were approved. It's such a good feeling of getting that response from a patient of I got my appeal decision letter and they said they're covering it. Now, that doesn't mean they're paying 100% for it because insurance is complicated. And I know for international scenarios like in the UK, I know numerous reproductive geneticists and genetic counselors over there. So I know they have a whole system. They do have testing available, but I think they also have guidelines on kind of what we need to be seeing on imaging or like family history in order to access some of that. So it's available, but kind of on, you have to meet certain criteria.
So
For the
have
US,
certain risk factors, and then you might
right,
be
right, yeah.
offered. Got it. And you had mentioned, like, I think with this is one of the challenging things about working in healthcare in the United States is navigating this conversation. You also mentioned navigating those emotional conversations. What would you say is the most challenging part about working in prenatal genetics?
I feel like the biggest challenge over the years has just been learning how to approach a patient to where I can gain their trust very early on and also show them I'm here to help them and not that I'm an ally, basically, regardless of their background, regardless of what they believe in. And I say that because, especially in the South, I mean, across the country, really, there's a lot of feelings about different reproductive decisions. And I've had other people ask me, like, how do you approach things like termination with a patient? Or, do they get mad or anything? And I really feel like there is a way to talk about these things with your patients, even ask about them and kind of their perspectives on it to get a feel of like how they're processing what's going on, what decisions they might make without, in short, pissing them off or completely destroying that relationship. And truly, it's one of the things that I think is just so hard to teach in grad school programs. And it really is a lot of trial and error and learning not just your style, but kind of how to approach certain scenarios and to have that good balance. And so that's kind of one of the bigger challenges. I'd say the other challenge, just in general, that I feel like has been more relevant probably in the last like 5 years or so, is just keeping up stamina. Of we see a lot of things in
Mm-hmm.
clinic, and I've gotten better over the years about like not taking work home or like, trying to do self-care for myself and everything. But we see just so much messed up stuff, not to be a Debbie Downer, but we just see a
Mm-hmm.
lot in prenatal care where there are days where it feels like, "Oh, can I keep doing this?" But the reason why I keep doing it is because I know like, someone has to be here for these patients and helping them through this. And I think what helps a lot with my job is my patients are so lovely. I it's truly one of the reasons I go back every day because I just have so much love for the patients I see and their families.
Well, and that was my next question was what's the most rewarding part? I think it's and some other folks have mentioned it, it's kind of, different sides of the same coin. It's some of the things that make it emotionally challenging or draining, also give you those opportunities to have it be so rewarding and to
Hmm.
be a support for the patients and like you said, an ally for the patients. Because I think sometimes people approach healthcare providers in an antagonistic relationship, but it sounds like you really see yourself as we're on the same team. I'm here to help you get what you need and meet you where
Yeah,
you're at. Mm-hmm.
right. And that goes for patients who continue their pregnancy, who don't continue their pregnancy, who lose a pregnancy. And I I really think there is this misunderstanding of prenatal genetics of, oh, we're just here to talk about abortion and getting you an answer for testing. And certainly some patients do go that route or do come in saying, I just want answers, but it's so much deeper than that for the
Mm-hmm.
vast majority of patients. And there are certainly some really sad situations that we see where you may never see them have like a quote unquote happy ending. It doesn't change how I feel about the work, even if I think back to a certain patient or their family of there's just nothing that felt necessarily like warm and fuzzy. I wouldn't change it because they really don't have a ton of specialized providers who will kind of walk them through that as much as possible. And I feel like our field for prenatal genetic counseling or reproductive genetic counseling, we're just in such a unique space where, yes, we do a lot of education, but we also have this big psychosocial component and being there through numerous stages of that patient's journey.
Mm-hmm. Mm-hmm. I agree. I think it is because there is that balance between the medical information, keeping up with current information, but also pregnancy can be a very stressful time where there's a lot going on, a lot of questions happening. And I think we've covered quite a bit, and I appreciate you taking the time to go through it's not a simple issue. There's different things going on. It's complex when you're talking about prenatal testing and pregnancy care. If our listeners walk away just remembering one thing from this conversation, what is something that you want them to remember about prenatal diagnostic testing? Like, what is the one thing
Right.
that you would hope they take with them?
Originally I said I would want the take home message to be that it doesn't, or it can't tell us everything. I've changed that now.
That's fine.
Right. I think the take home message I would have is diagnostic testing is not just a tool to help you know if you want to terminate a pregnancy. It is so much more than that. You may never feel like termination is an option. You may know you're going to continue no matter what. You may not know what you're going to do. You may know you're leaning towards termination. Diagnostic testing is there to give you more information to help really understand how it fits into your life, into your family, etc. That is very, very different for each person. And you really have to think too, like, not just how does it affect you in that moment, but to steal something from one of my dear friends and colleagues, Lauren Westerfield, shout out to her. She tells patients, I'm not just thinking about you in this moment, I'm thinking of the you in a few months from now or a few years from now. Like, there's a ripple effect with this diagnostic testing. But it is so much more than just a tool to help you decide if you're going to continue or not. And I think that's how it's presented a lot of the time when it really shouldn't be. It's kind of a long-winded answer, but that
No,
would be
I
the
mean,
take-home message.
I think that's perfect because I think that's really, what we're uncovering is that these things are much more nuanced. Like you said, it depends
Hmm.
on the specific patient, the specific family that you're working with, their specific situation. So there's a lot of things that go into it. So that's why sometimes it gets challenging when people say, "Oh, this is exactly what it is and how it will always be used." And it's like that's
Right.
not the case. Yeah.
Right. Exactly.
Well, I just appreciate you, like I said, taking the time. I think this was a really good conversation. It was nice for me to revisit prenatal genetics since I've kind of been out of that space for a while. So just thanks for talking. I appreciate
Yeah.
it.
Thanks for having me.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening and join us next time.